Welcome back to our explainer series, Decode Healthcare with Harshal. Today, we're totally shifting our mindset. We're moving way beyond just checking boxes, and we're jumping right into mastering the art of clinical storytelling. Because listen, as we look ahead to 2026, audit readiness isn't just some nice-to-have bonus anymore. It's absolutely essential for your practice's survival. Take a look at this contrast. On the left, we've got a note that simply says, wound improving, debrided. Quick, easy, right? But on the right, well, that's a stark, red 2026 audit denial just staring right back at you. Using vague words like improving, or even worse, just copy-pasting your previous visit notes, is quite literally the fastest way to fail a payer audit and risk some major recoupments. In 2026, debridement coding is not just about picking the right CPT code. It's about proving clinical necessity and demonstrating documented, measurable improvement. Building on that medical necessity baseline we set up in Part 5, our agenda today is going to give you a bulletproof checklist. First up, the clinical storytelling framework. Second, visualizing the wound bed. Third, exact procedure details. And finally, top compliance red flags. All right, let's get right into Section 1, the clinical storytelling framework. We're going to break down your documentation process into 4 totally logical, defensible steps. This is what transforms your scattered notes into a cohesive medical story. Here are the 4 core questions you need to answer every single time you chart. 1. What did you see? 2. Why intervene now? 3. What exactly did you do? And 4. How did the patient respond? The really crucial point here is this. If even one piece of this 4-part framework is missing from your chart, your compliance significantly weakens in the eyes of an auditor. The story is incomplete. And an incomplete story, well, that equals an unpaid claim. Let's break these down. First, what did you see? We have to establish the baseline wound status for today's specific visit. You need to clearly detail the exact anatomical location, the wound type, and exactly what kind of tissue is sitting in that wound bed right now. Are you looking at necrosis, slough, granulation tissue, or eschar? You've got to paint that picture crystal clear. Next up, why was the treatment done? The auditor desperately needs to know your clinical rationale. Why wasn't standard wound care enough? Why is this specific debridement intervention medically necessary right at this exact moment? For instance, CMS explicitly wants proof that basic care was attempted and failed before you move on to more advanced interventions. You need to document things like stalled healing despite, say, weeks of compression therapy. Then you have to answer, what exactly did you do? You really can't just write debridement performed and call it a day. You must document the exact procedure. This means the specific depth of the tissue removed, the exact surgical technique and instruments you used. Was it a scalpel, a curette, and the total surface area treated, measured accurately in square centimeters. And finally, question 4. How did the patient respond? Payers are absolutely looking for the outcome here. You must document the immediate post-procedure appearance of the wound. Did you achieve a clean, bleeding base? How much of that slough was actually reduced? And honestly, just as importantly, you need to document how the patient tolerated the procedure and the anesthesia. Moving right along to Section 2, visualizing the wound bed. Think of your clinical notes as a high-definition camera lens for an auditor who's going to be reading them months from now. You must explicitly characterize the wound you're looking at. Leave absolutely no ambiguity about whether it's a diabetic ulcer, a pressure sore, an avulsion, or a burn. Include objective signs like the amount of exudate or drainage, any odor or erythema that might point to an infection. Your words literally need to conjure this exact image in the reviewer's mind. And please, banish vague terms like healing well or looks better from your vocabulary entirely. Instead, use concrete metrics. You need to track the exact length, width, and depth in centimeters to prove measurable progress over your prior visits. The aggregate surface area rules are incredibly strict, and they calculate sizes in specific square centimeter increments depending on the CPT code. Precision is hands down your best defense. All right, on to Section 3, documenting exact procedure details. Because debridement coding follows the deepest tissue removed, you've got to detail your specific technique. Did you do a gentle, selective autolytic cleaning, or was it a surgical excisional sharp debridement? And if it is sharp debridement, you must document exactly how deep you went. Did you reach down to the subcutaneous fat, the muscle, or did you go all the way to the bone? Remember, the deeper you go, the different the code and the higher the scrutiny. You know, when you really look at it, clinical documentation is absolutely a team sport. Providers have to perform the clinical evaluation and document the exact area, depth, and technique.
Meanwhile, your coding teams act as the ultimate compliance gatekeepers. Coders aren't just there to assign numbers. They're validating that the measurements actually support the CPT units being billed, and they should definitely be querying providers if that medical necessity language is missing.
Which brings us to our final section, top compliance red flags. Now, auditors are actively hunting for specific high-risk patterns in your EHR. For instance, if a patient's healing has stalled, you must explicitly document exactly why and outline how you're changing your management strategy. Why? Because performing routine weekly debridement procedures and submitting notes without a single ounce of clinical variation or documented progression is a massive recoupment risk. Auditors are specifically looking to see if you recorded the exact same size and depth visit after visit. So make sure you avoid these top 3 traps. First, the copy-paste trap of repeating identical narratives week after week. Your notes must reflect today's unique reality. Second, the missing measurement trap, where you state a procedure was done, but you totally forget to document the length, width, depth, and total square centimeter area. And third, the no outcome trap, where you bill for the procedure but leave out the patient's response and the post-treatment state of the wound bed entirely.
To wrap up today's explainer, I want you to remember these 3 golden rules for audit-ready documentation. Number 1, every single session has to tell its own unique clinical story. No more copy-pasting. Number 2, always back up your CPT code selection with exact, measurable depths and aggregate surface areas in square centimeters. And number 3, always document the tangible clinical outcome and the patient's measurable progress.
So honestly, I have to ask, are your chart notes actually ready to withstand a 2026 payer audit? Take these frameworks back to your practice this week and see for yourself. Next time, we're going to put all of these rules to the absolute test in Part 7, Deep Dive Case Studies, where we'll walk through step-by-step clinical scenarios for initial versus follow-up visits. Until then, keep those measurements precise, tell the whole clinical story, and continue to decode healthcare with Harshal.